syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMD Demystified podcast.
Welcome. Glad to see you. If you're a newcomer, I am Tony Urbanek, and this is TMD Demystified live stream. If you are a returner, someone who has returned from prior episodes of TMD Demystified, doubly welcome. I appreciate you coming back. We are here always on a Saturday at noon to discuss temporomandibular joint disorder and why it needs to be demystified. We will discuss why it seems to be so complicated, which it's not. It's not. And this live stream is devoted not only to my colleague dentist, dental specialist, but especially to the public, and especially to the parts of the public that have TMD symptoms. It is my mission, it is my stated mission to bring this disease under control, and we are certainly able to do that. I can justify that, I can prove it. For those who follow me along and my information, there's plenty of other podcasts and blogs that I've written for the past 4 or 5 years that you can go to on any particular topic. But today, we're going to focus again on what appears to be hypocrisy of the American Association of Oral and Maxillofacial Surgery in treating this disease. And I must say, for any newcomers who have not heard me before, I am a board-certified oral and maxillofacial surgeon who has been practicing in private practice in Nashville, Tennessee and Franklin, Tennessee for the past 50 years. My practice primarily was devoted to the higher end of maxillofacial reconstruction in many areas: facial reconstruction, nerve reconstruction, cleft lip and cleft palate, and had a large portion of my practice for the first 36 of those 50 years in surgically treating temporomandibular joint disease. But roughly 15 years ago, I decided that surgery was not going to be the solution to this, and many of my oral and maxillofacial surgery colleagues in private practice have also made that same decision. That is verifiable and verified, for very good reasons. But because of my broad background in both dentistry and having a medical degree and a degree in cell biology and anatomy, and also spending 2 years as a fellow with the National Institute of Health, National Institute of Dental Craniofacial Research on the topic of facial growth and development, I felt I possibly had enough background to take a look at this problem independently and come up with a solution, which I did. But today we're going to talk about what is and what is holding up the show. Back in 2018, I attended a seminar, a consensus, which was put on by the National Academy of Sciences, Engineering, and Medicine in Washington, D.C. in March of 2018, specifically on the topic of why there has not been significant progress on the solution for temporomandibular joint disorder. And I remind everyone, it is a single disorder. It's not multiple disorders. There are certainly multiple symptoms, but you can't treat each of the symptom as a different disorder. because all the disorder is chronic inflammation within the joint, in this case temporomandibular joint, which creates each and every one of those disparate symptoms. So it's one disorder. It's the chronic inflammation creates the symptoms. If you treat each symptom as a separate disorder, you're making it much more complicated than it needs to be, and gets nowhere, because treating symptoms is at very best temporary, if you get any relief at all, by treating just symptoms. But if you treat the cause and make the cause go away, which is chronic inflammation, then you will get a solution to the symptoms, because the symptoms will either go away or not show up. So I remind everyone this live stream is intended to give viewers and listeners the opportunity to ask questions and get involved. If you'd like to debate me, if you'd like to question me, if you'd like to make comments, even if you'd like to criticize, I am open for criticism, but I warn you, I expect you, if you come to criticize, make sure that you define your terms and bring your documentation with you. So today we're going to go back to, for a little while, that meeting in March of 2018 at the National Academy of Sciences, Engineering, and Medicine, which was designed at the interest and from the interest of the TMJ Association, which was headed by a woman named Terry Crowley, who is now deceased. But at her behest, and with a lot of time and pushing into it, she got enough interest from the National Academy of Science, Engineering, and Medicine, NASEM, to put on this rather significant watershed meeting. Part of that meeting was open to discussion from the public and interest from the public and presentations from the public, of which I put on a 7-minute presentation about my findings, my observation, my research, and the results of my research here in Nashville, Tennessee. I placed that on a previous live stream, and you can return to that if you wish to see what I had to say about it. But today we're going to listen to a brief discussion by one of the attendants at that meeting early on, by the name of Diana Zuckerman, who was president of the National Center for Health Research. And I bring her to your attention because she presents what was at that time the general thought and the general interest or lack of knowledge about temporomandibular joint disorder. And then after we listen to her, I may stop it at a few points and make additional comments about her presentation, but I thought her presentation was very appropriate for the time, and actually is very appropriate for 2026 because things have not changed. That's the problem. The problem is things have not changed significantly when they certainly should have. And then when we finish listening to Diana, we're going to go back to listen very briefly to someone at that meeting that I also gave a bit of time to, which was Gary Below, Dr. Gary Below, who represented the American Association of Oral and Maxillofacial Surgery, and allow him again to put on part of his statements about the importance and use of surgery to treat the temporomandibular joint, in particular total joint reconstruction, which he tried to defend as best he could. But first, let's listen to Diana. I'm going to share my screen here and see if we can get this in motion. And then after this, we'll talk a little bit. I expect this to run about, no more than 30 minutes of my usual presentation. And then I'll be watching the live viewers. If there's anyone who has comments, questions, I will be more than happy to relate those and talk to at the end of the presentation. So let's hear what Diana has to say about temporomandibular joint disorder in March of 2018 at the National Academy of Science, Engineering, Medicine on the consensus of temporomandibular joint disorders.
Beth, big.
I'm here and I'm not a patient, but I will try to be brief and explain my perspective. I'm Dr. Diana Zuckerman. I'm president of the National Center for Health Research, and my perspective is as someone trained in epidemiology but who's been looking at this issue for, I think it's 25 years when I first met Terry Cowley. So I was trained as a researcher, and I was a researcher and a faculty member at Harvard and Yale, and then came to Washington, D.C. to be a congressional investigator working on health issues. And Terry Cowley approached me because of some work that I had been doing. I was looking at the safety and effectiveness of medical products and looking specifically at FDA's role in determining safety and effectiveness of medical products. And so we had a congressional hearing that got a lot of media attention in, I think it was 1992. And that was the first I had ever heard of TMJ. I didn't know anything about it before that, but we were surprised to find out that there were all these implants on the market and that FDA had never required clinical trials for them. So it took another 7 years. Despite all that attention, it took 7 years till FDA finally not only required that studies be conducted, but reviewed those studies at a public meeting in 1999. And I think that the FDA was pretty shocked at the quality of those studies. So there were studies, first of all, despite the fact that these implants had been on the market for many years, I don't think any of the studies went past 18 months. Very often, by the time they got to 18 months, there were only 3 or 6 patients left. They had basically lost a lot of patients to follow-up. And it even became public at that meeting that one of the reasons why there were so many patients lost to follow-up is that some of the companies were charging the patients to come back for evaluations. You know, exactly the opposite of what you'd want to do in a clinical trial. You want your patients to stay in the longitudinal study, but instead, if patients came back to be evaluated, they were being charged instead of being provided with some kind of incentive to be there. So the FDA said, gee, we really need at least 3 years of data, and then they ended up approving these implants anyway. So you ended up with a lot of implants that were FDA approved based on clinical trials that were really very poor. And I know we want to look forward and not backward, but I think it's important for you to know that many of these implants are still on the market, and we still know very little about their long-term safety and effectiveness. And that's part of the lesson, I hope, and part of what we need to change moving forward. So as far as I can see, there's still a lot of unanswered questions about what works and what doesn't. I've met with and talked to many patients who've been harmed by surgery, by implants. I will say that some years after I first got involved in this, my teenage daughter came to me and said, I have this clicking noise and it's really bothering me. And because I had been in this known about this, I said, well, let's just see what happens. We're not going to do anything about that. And she's fine. You know, she's now 30, and it went away for her. So, you know, that's an N of 1. I'm not saying that always happens, but don't we want to know when it happens? And don't we want to try to figure out for which patients that might be true, that no treatment's better than any treatment? And one of the last concerns I want to mention is that I know that registries are being discussed and can be very important, but I also know that, at least with the FDA's involvement with the registry, they're really focusing on patients who've had surgery or had implants, and they don't think it's practical to have a registry of patients who haven't had surgery or haven't had implants. And that would be, I think, terrible, because we would lose all that information that we want about the patients that how they do if they don't have surgery and if they don't have implants. I think that's really all I wanted to say, except that I've been very impressed with what I've heard, and the knowledge and open-mindedness of all of you, and that I hope that when you come out with your recommendations, that you will be looking at that broader picture of what we don't know and what we need to know, because when it comes from you, it will mean a lot more. Thanks very much.
Thank you, Diana, and thank you all.
All right, so I think that was very appropriate and concise regarding what the thought process is currently and what the thought process was back in 2018 regarding the surgical and as was mentioned, non-surgical issues having to do with temporomandibular joint disorders. Specifically, I want to bring to your attention her statement that there is at that time no registry for patients who did not have surgery, and there was an attempt later on to develop a registry for temporomandibular joint patients who did have surgery. But I bring to your attention that it was my study, which was a 2020 study, which was actually a registry of my own 3,000 temporomandibular joint patients. There was an independent study from Middle Tennessee State University with the intention of having a registry for my 3,000 patients treated non-surgically, which showed that treated correctly by unloading the temporomandibular joint according to a protocol using a very simple intraoral device that separates the posterior teeth long enough to unload the temporomandibular joint. According to a protocol, very important that you follow the protocol along with the device. But a registry was done by a single doctor here in Middle Tennessee, yours truly, which showed such great success on the non-surgical treatment of this problem. So the Association of Oral and Maxillofacial Surgeons back in 2018 sent Dr. Bellew to discuss, and in my opinion, to justify surgery on the temporomandibular joint, specifically total joint reconstruction. And I will attempt to bring him to your attention, if I can find the right position. There we go. So we're going to listen to the first few couple minutes of Dr. Bellew's presentation, specifically about what he has to say about multiple operated joints. This is going to come in to the mix as I proceed, but just keep in mind multiple operated joints versus a single operation, and what is called total joint operation, total joint reconstruction, very similar to a total joint reconstruction done by orthopedic surgeons on a knee or a hip. So let's listen to what Dr. Bellew has to say.
In the clinical aspects of managing temporomandibular joint dysfunction. To start first, I'd like to say thank you to Jennifer, Tricia, Lisa, Michelle, and Alexandra. The stories really are heartfelt and truly appreciated. It really tells a very sad story. There's a very common theme amongst the majority of the patients that have spoken today, and that is the multiply operated joint. We know and have known for a long time that that really bodes very, very poorly in terms of outcomes. And it really is a sad tale of iatrogenic injury. I would like to think that in today's world and with our current research that no one would ever consider doing and going down those roads that you've been asked to go down. I know that would be the case at Emory and many of the academic centres, but I wish I could speak to everyone who does TMJ surgery in that regard. Sorry. Multiply operated patients end up with neuropathic pain, they end up with centrally mediated pain, and that just can't be ameliorated by additional surgery. We know that, and we have to be very careful in terms of preventing that.
So let me just stop right there and just emphasize how Dr. Bellew who is the chairman of the oral maxillofacial surgery training program at Emory in Atlanta. He makes the case for multiple operated joints. As a oral maxillofacial surgeon myself, with over 2,000 temporomandibular joint surgical procedures, half of them open joint procedures with an incision in front of the ear, and half of them arthroscopic procedures. I've done them all, including many total joint reconstruction. He started out by focusing on the multiple operated joint. And I can tell you with certainty that you can have very significant problems with the initial operation of the temporomandibular joint. So to kind of justify the position of the prior patients who discussed their problems with temporomandibular joint and blame it on the multiple operated joints is not appropriate. It's not fair. It's not an appropriate presentation itself. But let me continue for a minute, and then we'll wrap this part of it up.
I think iatrogenic injury, as has been reported here, is preventable. And to that regard, being on behalf of AMOS here and the American Society of TMJ Surgeons as a group of us, I think we would all strongly support the development of guidelines both for TMD diagnosis and for TMJ surgery. And I think we could get that adopted by both AMOS, ACOMS, and ASTMJ, which would represent 10,000 oral maxillofacial surgeons and really cover 95% of individuals who practice in this country.
All right, so he wants to have basically a position paper written, which actually was written, and the position of American Association of Oral and Maxillofacial Surgeons on the temporomandibular joint, which he was the lead author. This paper, I believe, came out in 2024. But it was a position paper on how oral and maxillofacial surgeons should go forward in considering doing surgery on the temporomandibular joint. I can tell you that right now, in 2026, there are almost no oral and maxillofacial surgeons who want to do temporomandibular joint surgery who are in private practice. There is temporomandibular joint surgery done in the training programs, and I think there are various reasons why it is limited there. But most oral and maxillofacial surgeons in 2026, as opposed to 1980s, early 90s, who did a lot of temporomandibular joint surgery like myself, in 2026, you can hardly find an oral and maxillofacial surgeon who wants to do any kind of arthroscopic surgery or open temporomandibular joint surgery. So he commented that it would be appropriate to have a position paper from the American Association, of which it was created now in 2024. And part of that position paper, of which he was lead author, talks about the appropriate way to manage temporomandibular joint problems. And one of the paragraphs in this paper I'm going to read. It's basically, the title of the paragraph is, the proper way to think about it is initiate the least invasive, evidence-based, non-surgical or surgical treatment. So first you do the least invasive, evidence-based, non-surgical before you consider doing surgery. Their definition of non-surgical treatment for temporomandibular joint disorder is non-surgical treatment for the management of TMD may include rest, heat, ice, non-steroidal anti-inflammatory drugs, muscle relaxants, physical therapy, and orthotics. What is an orthotic? An orthotic is something that goes between the teeth when it comes to temporomandibular joint. When it comes to TMJ problems, definition of orthotic would be something that goes between the teeth. If you are a orthopedic surgeon, an orthotic may be something that goes in your shoes or something that supports the leg itself. But when it comes to TMD, an orthotic is defined as a device that fits between the teeth somehow. And we now know that 50% of dentists make an orthotic that doesn't have anything to do with temporomandibular joint, and that's called a night guard. A night guard is a very simple device that protects the teeth. Let me switch back here. Very simple device that protects the teeth. Does a good job of protecting the teeth by covering the surfaces of the teeth. So if you put extra loads on the teeth themselves by bruxing, you can't break your teeth. And it is very common for people to fracture completely or partially their teeth due to clenching or grinding bruxism, and a night guard is very successful so that you won't break your teeth, but it has no effect on the temporomandibular joint inflammation, and frequently it makes it worse. But that is an orthotic. But an orthotic that actually makes the inflammation go away within the temporomandibular joint by unloading the joint, like a set of crutches unloads a knee, or a sling unloads a tennis elbow. Is very important and very appropriate treatment. So unloading the temporomandibular joint does the same thing as crutches or a sling, and is very simple, and it's definitely non-invasive. And that is my point about this. And the secondary point is Dr. Boulot, his own position paper, states that it is the most appropriate thing for a surgeon to think about and do before he considers doing surgery. And with over 2,000 temporomandibular joint cases under my belt, and my decision 15 years ago that TMD surgery was not going to be the long-term answer, and doing the actual research, which is documented on this independent study done through Middle Tennessee State University with a investigational review board oversight and monitoring, based on 3,000 successfully treated patients non-surgically. It is my position that it is extremely rare for a oral maxillofacial surgeon to have to do any kind of temporomandibular joint surgery, and especially total joint reconstruction, as opposed to the point of view of portions, not certainly the entire American Association of Oral Maxillofacial Surgeons, but portions of the American Association, that is the temporomandibular joint surgeons within the temporomandibular joint, within the American Association, who try to convince the public that total joint reconstruction is an appropriate treatment. I just bring to your attention that I have documented on podcast number 100, 17 patients who had terrible degenerative change, partial or total destruction of the temporomandibular joint system itself, condylar head, glenoid fossa, destruction of the bony portions of the temporomandibular joint, who under my first 36 years of oral maxillofacial surgery would have been treated easily with temporomandibular joint surgery and likely total joint reconstruction, who I treated several years ago and showed not only what the symptoms were, but how much the bone was damaged. And then I followed that with what the patient had to say about their success and amelioration of the symptoms without surgery. I had 17 cases that I documented just as a celebration of my 100th podcast several years ago, and showed that just unloading the joint without surgery, according to a protocol, was much more beneficial than surgery itself over a long period of time, and studied by an independent university study. All right, with that said, I have been watching the viewers, and I don't notice any comments or questions at this time. I've been going about 30 minutes. I don't want to bore everybody, and I want to make my point and then go on. I think that I will continue this particular arena, this area around the meeting in 2018 in Washington, D.C., with I think one, maybe two more speakers who I want to allow to make their point about temporomandibular joint problems. I think the next one I will discuss or allow to speak in front of you is a patient who will give you a viewpoint on how terrible these symptoms are in ruining their life, making a tremendous negative difference to their life, and then comparing that to non-surgical treatment of the temporomandibular joint. And the other point I think in the future we will address on this live stream something that came across my path here very recently, and that is the lead article in this month's Dental Economics, which is oral health is systemic health. And again, I've written many articles and done many podcasts on the fact that inflammation on the temporomandibular joint has similar negative detrimental effects on other areas of the body, other organs of the body, other diseases of the body, very similar to periodontal disease. And we'll cover that later on. But I think that's also a topic coming down the pike that I want to cover on the live stream and give people, especially patients, an opportunity to ask questions and get involved if you'd like. So with that as a area of interest for the future, I see no questions or comments. I'll wrap it up today and hope to see you in the future on Saturday. But to make an announcement, next Saturday's live stream will not take place. I'll be traveling. I'll be out of town. So the next actual episode of live stream TMD Demystified will occur on Saturday. 6 plus 7 is 13th. The 13th of June. I am Tony Urbanek, and this is TMD Demystified live stream.